To diagnose TB, we still use sputum smear, and we also now started using a lot of a new technology called expert TB, which is basically a PCR or a NAT test, and it does give a very good sensitivity and specificity, and that's being now deployed in many dot centers, in many diagnostic centers. But the gold standard is to do a sputum culture, but usually it takes a long time. In terms of genotyping, it's not commonly done, but it's very useful in Western countries like where I live. In Australia, it's a routine test to do to understand the genotyping. But for the Indian perspective, we do use NAT test, PCR, or expert MTB, where you find resistance for single drug, either isoniazid or rifampicin, because that gives a 70-80% sensitivity range against the drug. So a very good test, but it's now being widely deployed in India. To diagnose latent TB infection, you need to do tuberculin skin test. Now, if you look at the first slide, I told you we're using old tools. So if you look at chest X-ray, which is very commonly used, it was discovered by Röntgen in 1870s. And if you look at tuberculin skin test, it was discovered sometime in 1930s or 1940s. Sputum smear again. Robert Koch discovered this in 1860s or 70s. So all of these tools are, the mainstay of diagnosis, and you can see that we are using that even today. There's not been a lot of progress in terms of diagnostics. And then just want to focus a little bit on the TB drugs. I don't want to go through each and every one, but just want to highlight the year of discovery of these drugs. You can see that isoniazid was discovered in 1952, rifampicin 1963, ethambutol 1962, pyrazinamide 1954, streptomycin 1949. The first top 5 are the most commonly used first-line drugs, and you can see they have been discovered in 1960s. And there's not much of a drastic improvement in the TB treatment strategies. We have not used new treatment drugs. So, Dolly, it's not a joke. 90 பேர் இருக்கிறான், please. Sorry about it.
No worries, no worries.
So there has been a lot of drugs, but we know that all of these drugs are old, and not much of investment has been made in terms of discovering new drugs. If you look at contrast this with HIV, you can see that every 6 months there will be a new drug for HIV, and this is a very important comparison statistic, because HIV mostly affected Western countries, and a lot of money has been pumped into the new drug discoveries, and whereas TB has traditionally affected low and middle income countries, and very little money has been devoted to R&D of new drugs. So you can see that we still use old diagnostic tools and old treatment strategies. So the way we want to treat TB is that we want to attack TB with 4 drugs for 4 months, and another 2 months we want to give 4 drugs. And the why we give multi-drug therapy, most of you would know, it's because we want to kill both fast-growing and slow-growing bacilli. And it's very important that we do this. Otherwise, what will happen is people will develop drug resistance. So that's the reason why we give multi-drug resistance therapy. So this is the current recommended schedule. And if you can, it's very important that we follow this treatment schedule. The reason is simply we want to avoid drug resistance. We do give vaccines for TB, but you have to know that vaccines not fully effective, and it only helps in preventing serious forms of disease in young children, especially miliary TB and serious meningeal TBs in young children. So in Western countries, they don't give vaccine as a routine in high-income countries, but we do follow that in low and middle-income countries. WHO recommends that in spite of its limited impact on control of TB, because it does help severe forms or in preventing severe forms of TB among children. So this is the test I was talking to you about, the expert TB test, and it's now being rapidly mobilized in many DOT centers. I think they covered more than 40-50% of DOT centers in India, or maybe more than this at this stage. It's really good because you give a sputum sample and you get the results in 2 hours, and it detects it's a molecular test which detects DNA in the bacteria and also detects genetic mutation associated with rifampicin. And there are lots of advantages. The only disadvantage is that it needs to have a constant power supply, and you need to have a technician who needs to read these tests. So one good thing is there are lots of new drugs which are now being developed in the pipeline, and lots of new diagnostics which are coming up, and newer vaccines are also in the pipeline. But all of this are not enough, but we need to do a little bit more in terms of TB control, and we'll see why it's really important as we see the numbers. So let's go into the epidemiology. And if you all have your app, if you have downloaded the app, let's work through the app, and then we can we can learn through the app also. So just want to, before we go into that app thing, let's just go through this slide. And this is the top 10 causes of disease, top 10 causes of death in the world globally. And this was from 2019, just before COVID, but still relevant. And you can see that in this, the top maybe 15 causes of death in the world. If you see tuberculosis, actually, it's ranked 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So 13th in the rank. So the interesting thing I want to point out is that if you compare this with HIV, HIV is right in the bottom. And the numbers are not very clear, but the number of deaths caused by TB is actually double the number of deaths caused by HIV. So it's very interesting to know TB is the single largest infectious agent causing death around the world. And it's a very serious problem. And a lot of people do not actually pay attention to this. To quote the exact figure, in India, 1,400 people die every day. So as we are speaking today, March 24th, 1,400 people have died in India because of tuberculosis alone. It's a very serious problem. And just to highlight this, this is very important to know where TB sits in the grand scheme of things. This is another slide which shows the TB incidence rates. Basically, you can see that India is in a darker green zone, roughly about 150 to 180 per 100,000. So every year we get 3 million estimated cases, and we will talk a little bit more. But just want to highlight that in terms of new cases, India is still not as bad as African region where the incidence is very high, compared roughly about 354, something like 350. And still we are doing better, but I think we still have a long way to catch up. In terms of the global epidemiology, we have about 10.6 million new cases in 2021. And there's a big jump from 20, so this is 2021 from 2020. And of that interesting thing I want to highlight is that this is a mathematical estimation. So based on, many zero prevalence studies, national TB prevalence surveys, WHO takes the prevalence surveys and they estimate this number. So according to that, there should be 10, let's say 11 million cases. But if you look at the reporting, only 6.4 million cases are actually notified. And this is actually a very important thing to understand. So you have, let's say, 11 million cases occurring every year, but only 6.4 million cases actually getting notified. So when I say notified, which means they are actually coming into the system and they're getting treated. So let's just to for an understanding purpose, let's say there are 12 million cases and only 6 million are getting notified. Nearly 50% are not getting notified. So as per this figure, as per this statistic, nearly 40% of TB patients are actually not getting notified every year. This is every year. So imagine every year burden keeps piling up, okay? So a lot of people are not actually even getting notified into the system. They're not getting treated. They're not getting followed up. So we don't know what's happening to them. So it's very important statistic, very important thing. And it's very useful for us to understand why India is struggling with the problem of TB. And during COVID, there was a big dip in notification. Obviously, a lot of resources were devoted to controlling COVID. So we were, we funded a lot of money for COVID control. So we didn't have money, or we didn't have resources, manpower for TB, and therefore there was a big notification problem. And there's 500,000 multi-drug resistant TB cases, but only of that 500,000, only 125,000 are detected and reported. And as I told you, like nearly 1.4 million deaths happen every year. So of this slide, the one thing you have to take away today is that 40% of TB cases do not even get notified throughout the world, okay? All right. So if you ask which country is the #1 burden country in the world, unfortunately, not a ranking for India. India ranks #1 in terms of global picture. So if you have about 10.6 million cases, 3 million cases occur in India alone. Okay?